Normal lung function involves breathing and it involves coughing, and both are things we take for granted. Breathing awake and breathing asleep are a little different. As I'm talking to you, I'm controlling my breathing so that I'm breathing between sentences, as an example. While we're sleeping, we're more on autopilot and we breathe in more of a metronome fashion and taking a sigh about once a minute. A patient with Duchenne muscular dystrophy can have a great deal of loss of respiratory function and never know it. Never know it until he gets sick. So let's talk for a moment about the stages of respiratory function in Duchenne muscular dystrophy. There are 4 stages. The first stage occurs from birth to around age 10 or so, normal respiratory function. And it could be a little younger depending on the patient. With normal respiratory function, a person has a good ability to clear secretions with coughing, breathes fine awake and breathes fine when they're asleep. The second stage is their breathing is okay, but their cough becomes inadequate. This stage occurs sometime after the boys are in wheelchairs. So it never occurs while the children are ambulatory. The point at which they lose their ability to cough is variable and it can be easily anticipated based on simple spirometry, which is a word meaning pulmonary function test where you breathe out and the amount that you can breathe out and the speed at which you can breathe out are measured in a laboratory setting. The third stage of Duchenne muscular dystrophy involves both not having enough ability to cough, but now you can't breathe sufficiently in sleep. And the fourth stage involves not being able to breathe enough when you're awake as well as when you're asleep. And that occurs late in Duchenne muscular dystrophy. There are specific approaches to all of them, and there's a lot we can do for all stages. During the stage of Duchenne's in which there's normal lung function, the guidance is more anticipatory and the interventions are prophylactic. So what we'll do is make sure the children are receiving flu shots, influenza vaccinations, and make sure that they have received the full series of vaccinations against pneumococcus. Under age 2 it's called Prevnar, and after age 2 there's a shot called Pneumovax. We like to make sure the children are as well protected against that bacterium as possible. The second stage of Duchenne muscular dystrophy involves having inadequate ability to clear secretions with coughing. The patient can be completely asymptomatic and be well into the middle of this stage and never know it until they get sick. And they'll be fine, they'll be breathing fine, and they won't really have to cough because they haven't had a cold, and then they'll get a cold, and then those they can't seem to bring the secretions up. And the first cold they may have will linger a long time, and it'll be a long time. Maybe they'll get some antibiotics from their physician, but they'll notice that it took several weeks to clear that cold. And the second cold, it's even worse. And the parents are noticing just a great deal of difficulty. Perhaps the child will develop a pneumonia at this point. This stage can be anticipated, and hospitalizations can be prevented by getting pulmonary function tests on the children so that we know when they are in this stage. This stage can be well predicted and anticipated by use of pulmonary function testing, or PFTs. With pulmonary function testing, we are measuring the amount of air they blow out and how rapidly they blow it out. We look at the level of function based on the percentages, based on age and weight and sex and height. And if the level falls below a certain critical value, we recommend starting to teach parents how to assist coughing and that parents obtain a mechanical device to assist coughing. What the level is depends on the age of the child, but in general, if the peak flow with coughing is less than 270 liters a minute, that's when it's time to get the Emerson cough assist device and to teach parents manually assisted coughing. The deepness of the breath, the size of the breath, can be assisted with an ambu bag, which is a plastic bag that blows air into the lungs. Take a deep breath, and then the parent squeezes the chest or compresses the abdomen, and the child coughs on cue. If the level of peak of flow with coughing is below 180 liters per minute, then the child is at significant risk for developing pneumonia. We like to be seeing any child who's in a wheelchair every 6 to 12 months so that we can get the pulmonary function test, it's probably worth taking a moment to talk about what is a normal cough, what is involved with normal coughing, and why do Duchenne's patients have difficulty with coughing. A normal coughing involves 3 phases. The first phase is taking a deep breath because you want to get the air behind the mucus, the secretions you want to get out of the lungs. The body is very sensitive to the secretions, and so when we get secretions in our chest, we automatically cough. We don't even think about it. So you take a deep breath. That gets the air behind the secretions. The next thing you do is you close your voice box. And then the third thing is you squeeze the muscles of the belly. And that pushes the abdominal contents up against the diaphragm, and it increases the pressure within the chest. And then you release your glottis, your voice box, and that allows the air to rush out at a high velocity. And one of the reasons that the air rushes out at such a high velocity is because the high pressure within the chest from squeezing your belly muscles results in a compression of the airways. And so just imagine if you hold your thumb over the end of a hose, the water shoots out faster. The same thing happens within the airways. The trachea narrows and compresses. And so you open your glottis, and out rushes a flow of air at high velocity, shearing secretions off the walls of the trachea and bronchi, and moving secretions from the periphery of the lungs into the central part of the lungs, and the secretions from the central part of the airways out. And so it takes several coughs. The goal of coughing, of course, is to clear the lungs of secretions. And why is it that when I get a cold, I don't develop a pneumonia, but a patient who has very weak muscles is at risk of developing pneumonia? Is that the secretions stay there, and they cause collapse of the lungs behind the secretions, and they get the bacteria invade, and because they have a medium for growth, the mucus, and the bacteria grow and multiply and invade, and suddenly you have pneumonia. And so something is just as simple as just mechanically clearing your secretions prevents pneumonia. And it's not enough to give antibiotics and say, oh, my child's on antibiotics. Because what you'll do is, if you don't clear the secretions, you will select for the bacteria that are resistant. And so just being on antibiotics often isn't sufficient. The critical part is clearing the secretions out of the lung. And getting those secretions out, it takes some work, but it can be done successfully. And the critical part is anticipating when that is. We can very easily tell the patient when that's going to be, and they're going to need to learn how to assist coughing, both mechanically and manually. And the combination of the two, with Emerson's cough assist device, and in conjunction with an abdominal thrust or a thoracic squeeze at the same time, very effective. Stage 3 can also be anticipated. Now, stage 3 is the stage in which there's not enough coughing, but the breathing while asleep begins to be insufficient. The parents whose children are not breathing enough in sleep usually know it on some level, but they don't know it because it can be very subtle. And I'm going to enumerate for you the signs and symptoms of not having enough breathing during sleep. The most common sign is the children are awakening a lot at night. Parents might notice that prior to being in this stage 3, that their child might awaken once or twice a night to be repositioned. And because we all wake up several times a night, the typical adult will get up and go to the bathroom, or will just get up and roll over, and that's a normal thing. We have to be able to move during sleep. Prevents pressure sores and the like. So we have 4 or 5 awakenings during normal sleep that we don't usually perceive. You just roll over and go back to sleep. That's normal sleep cycles. So it's normal for a Duchenne patient to have a little help during the night once or twice. But when I hear that suddenly it's 5 and it's 6 and it's 10 times a night, that's the first sign that the problem isn't that they need to be repositioned. The problem is they're awakening because they're not breathing enough, and their body sets off an alarm saying, there's not enough oxygen here, wake up, breathe more. And so that's the first sign. Patients will often complain of nightmares. They're awakening several times a night with nightmares, and the nightmare they have usually involves a sensation of smothering. Why? Because they are smothering. They're not breathing enough in sleep. So when I hear about nightmares, That child definitely needs to have some help with breathing during sleep. Other signs can be morning headache. They wake up with a splitting headache in the morning. It's very worrisome for having this insufficiency of breathing during sleep. Other signs can be school problems. A child who's done well in school suddenly begins to have school failure because their quality of sleep is so poor that they can't attend to tasks and their ability to focus on class is not good. And so a decline in school performance is often seen in these children. Finally, they can have excessive daytime sleepiness, or fatigue. They just have no energy, and because they're just sleep deprived, and so they feel much more tired. And so there's a sudden change in direction of how things have gone. And so it can be very subtle. It can be just as subtle as a decline in school performance or fatigue or a bit of a headache from time to time in the morning. And so when I hear about these symptoms, I'm very quick to ask for some studies of breathing during sleep. There are two main kinds of devices that help Duchenne patients breathe during sleep. One of them is called BiPAP. BiPAP stands for bi-level positive airway pressure. And it gives 2 levels of pressure, and it helps the lungs inflate. BiPAP is very commonly used and requires an interface that is usually a nasal mask or a mouth and nose mask or a number of different interfaces. And it is a bit of an emotional hurdle for parents when we come to stage 3 and we say, we need to help your child breathe during sleep. They think, oh no, it's the beginning of the end. This is terrible news. And they're upset and unhappy. And I say, no, this is not the beginning of the end. The point of using BiPAP or any other respiratory assist device is to keep the road long ahead. Starting this ventilatory assistance in sleep is a bit of a hurdle. The main hurdle is just getting used to it. And so I usually, for the first few nights, will give the child or a young man some Valium or lorazepam or a drug similar to that, just to take the edge off the anxiety of having something strapped onto your face. And that really helps a lot. And once they get used to it, they don't need to be on any kind of medication for sleep. And they find that they sleep so much better that they welcome the device. The device that's on the other side of the mask can be a volume ventilator or can be BiPAP. Both devices are acceptable and work. Stage 4 is the stage in which the breathing awake and asleep is insufficient. And of course, the coughing is insufficient. During stage 4, the patient notices that he cannot speak a full sentence. So he'll talk and he'll have to interrupt his sentence with breaths. And so one of the early signs that the patient has entered stage 4 is an inability to complete a full sentence without having to interrupt himself. Pulmonary function tests can easily detect insufficiency of breathing during sleep or during awake hours, and we will begin to assist breathing awake. We have taken an approach that's advocated by John Bach from New Jersey of using non-invasive ventilatory support for these patients. This usually involves a ventilator that's attached to a mouthpiece, and the mouthpiece is left near the patient's mouth. And so all he has to do is turn his head slightly, grab the mouthpiece, inhale, take a deep breath, and he moves on. It's surprisingly easy to get used to this. I think that the physical therapy of the chest is very important, and it's probably worth mentioning that anything that encourages deep breathing is going to help keep the chest wall limber. And that's why swimming is really helpful. And some of these devices, like incentive spirometers, are helpful just to keep the chest wall expanding. Because if your chest wall is always kept in one position, just like if you kept your leg in a cast for 3 months, you're going to have difficulty stretching your leg out. You're going to have some contractures. So I think that being able to move your chest, take deep breaths, that's probably very helpful for parents of younger patients to encourage. I do that not to help strengthen the respiratory muscles, but to keep the chest wall limber. And I think that should be a good philosophy for long-term care in Duchenne patients. I try to be a very strong advocate for my patients, as does my entire team of caregivers. They're physical therapists, the social workers, the respiratory therapists, the nutritionists. But the single most important advocates for my patients are their parents. And I tell parents, if they're not getting what they need for their child, then they need to find another physician. It's really important to take a really aggressive and interventional approach toward the care of their children. Because so much in Duchenne can be anticipated, the problems can be anticipated, and the solutions are out there. And if we can get the solutions to the parents before the problems occur, then these kids can be leading long, healthy, happy lives.